Hey, we are live now. Hi, everybody. I'm Andressa. Um, I'm a medical student from Brazil, and today the main topic of our Rural Cafe is about nurse and allied health on rural. And we have Kathleen. Yeah, it's Kathleen. No, here.
It's Ilsa. Sorry, I've had to log in.
Ilsa. Oh, okay.
I realised you needed a Google address, so I had to borrow one quickly. So I've come up.
Ilsa, okay.
Yeah.
Thank you so much for your presence here. I'm very happy. And well, I'm going to be very sincere with you. I have not an expertise on this topic, but I guess this conversation will clear up something and that is watching too. It will be very good. Could you please present yourself to people who are watching?
Yeah. So my name's Ilsa Nielsen. I'm the.
Hey, Ilsa?
Hello. Can you hear me?
I guess.
Can you hear me, Andressa? No. Hello. Can you hear me?
Yes, I'm listening. Yes, I'm hearing.
Oh, good, good.
If yes, can present yourself?
I'm Ilsa Nielsen, and I am Director of Allied Health with the Allied Health Professions Office of Queensland in Northern Australia, and I manage the Allied Health Rural Generalist Pathway for the state health service within Queensland.
Okay. So, Ilsa, can you explain a little bit more about um, how is this working on Queensland? Um what do you do there, and what are your backgrounds and in this work on this job on rural?
Mm-hmm. So Queensland is a large state, quite decentralised, with the capital city in the way down in the southeast corner, and with a lot of rural and remote areas. Allied health in Queensland includes 18 professions. Some of those aren't in rural areas. So we have 10 professions in rural areas, main professions in rural areas. And we have, so we have since 2014 been developing an allied health rural generalist pathway. The rural generalist pathway is similar to the medical rural generalist pathway. We've used the model of the medical rural generalist pathway, which is also here in Queensland and has been for a number of years. So the Allied Health Rural Generalist Pathway focuses primarily on early career practitioners, so from graduate through to sort of a proficient rural generalist practitioner. The pathway at the moment covers 7 professions: nutrition and dietetics, occupational therapy, pharmacy, podiatry, physiotherapy, speech pathology, and medical imaging. That was only 6: medical imaging, radiography. In the next 12 months, that will be expanded to social work and psychology. And when that occurs, then we will cover pretty much all of the practitioners. So 9 of the professions and about 98% of practitioners in rural areas. And the rural generalist pathway, as I said, it's similar to medicine insofar as it's a development pathway for the individuals involved. There's a formal education program, a graduate diploma of rural generalist practice, which is offered by James Cook University, one of our local universities within Queensland. And the trainees are in designated training positions with allocated development time. They undertake the formal qualification at James Cook University, and their training pathway is about sort of between 3 and 4 years. So that's pretty much it. And also as part of the pathway, we have some leadership and higher level skills development for our existing sort of proficient rural generalist practitioners as well, so that they can support service development and education and training of their generalist trainee staff.
And how is the formation of, for example, if I want to do nursery and or another profession in health in my graduation, for example, here in Brazil, there are different graduations, and then when we finish this graduation, we go and work on. If we want, we can work on uh, health units that are kind of um, general practice in communities. But my question is how this works in Australia colleges, for example. If you are someone that are doing nursery, and what are the expectations, what you have to get and what you have to learn, and is it very different from working in urban or working in rural? Because Australia is a big country and there are a lot of rural areas, yeah.
Yes.
And
like Brazil, I'm sure.
Yeah, like Brazil.
Yeah.
But here we are concentrated in urban centers, most of medical schools. So my question is also if schools of nursery and other professions are concentrated on urban, or they are more in rural areas too.
We have not so much rural areas. We have a few regional universities in Australia, one of which is James Cook University, that does our rural generalist program, that delivers the rural generalist program. There are a number of other regional ones that have a rural focus, or metropolitan universities that have a rural campus where students would undertake part of their training, or at least their clinical placements, in rural or remote areas. So Flinders University, for example, is based in Adelaide, but it has a connection with Alice Springs in the centre of Australia. And Charles Sturt University is based in a regional rural area. And all of those, Flinders, CSU and James Cook University, all have a number of allied health professions. Usually most of them have the therapies and dietetics, podiatry, those sort of disciplines. So coming back to what does someone do so early career practitioners, if they want to be a rural generalist and they're interested in rural generalist practice within their profession, the rural generalist training positions are literally positions. So they would apply for a position just as you would apply for a position in a metro area. But the position is specifically identified as a rural generalist training role. The difference between the metro position and a rural generalist training position is the training position has some additional advantages. It has designated time between 4 and 8 hours a week for training and development. There are some supervision requirements around it. the funding for the rural generalist program, the education program, is inbuilt into the position, which would not necessarily be the case in a metropolitan area. So the rural generalist training role, similar to medicine, is basically it is emerging as quite a well-defined sort of package of benefits that relate to the progression or the commencement and progression of an individual within a rural generalist career. And in terms of the difference between metropolitan and urban and rural practice for allied health professions, I think the theme of it is probably, it is quite similar to medicine insofar as there is a very strong generalist role. The need to have a reasonable level of understanding of the range of health conditions that may impact your community, because often rural or remote allied health professionals will be the only one or one of only a couple of practitioners of their profession within the location. So it's that generalist scope of clinical practice, cradle to grave, across settings, inpatient, outpatient settings. And also in Australia, one of the defining features of rural generalist practice for allied health is that there are very few allied health. They're very thinly scattered across the country. And so allied health professionals in rural and remote practice need to deliver their services in a different way to an urban centre. So practitioners in urban centres generally will use telehealth less. Rural practitioners will use telehealth much more. Also use allied health assistants and support workers more, or at least in a different way, with more remote supervision. Rural and remote practitioners are more likely to skill share tasks between different professions. So professions pick up tasks that are probably historically or done by other professions in urban centres. And use partnerships more. Partnerships with, for example, Aboriginal and Torres Strait Islander community-controlled organisations, partnerships between government services and community-controlled services, which would probably be more common in rural and remote areas than it would be in urban.
Understood. Nice, really nice. And this is very important. Yeah, when we, I guess this work on allied health is so important. But lots of people in the organization systems of the municipality or towns haven't paid attention to the importance of this allied health on health work on rural. And here in Brazil, uh, it happens that in some places um, you have a team, but one of the professionals just have to travel to lots of teams. It is not a team closed. Some people just go in many teams in the same town, or sometimes in one or two towns, to do the work. That is, um, most of the times it happens with the doctor. Sometimes the doctor have lots of teams to work, a few hours in each. It is not so good for uh, the care of people in a long way distance, yeah, because it loses the relationship with the patient. Yeah.
Mm.
But as they are so few in rural scenarios, sometimes the organization of health of the town just say, okay, you can spend 2 hours here and then 2 hours there and then 2 hours, 3 hours there in the same town, but in lots of places.
Mm.
And uh, there's another thing, but this is a good one, that is called the Nucleo of Family Health, that is composed of psychology and physiotherapist, and sometimes a physical professional that teaches physical education. And then this team, it works helping the doctor and nurses in any doubts they have. So if they have, oh, what can I do if uh, my patient has schizophrenia or depression, um, very difficult depression, and I want a opinion from a psychology or another professional, and then they go and help the team of that place. It
Mm.
is it is a good I in my opinion it is a good work because it helps the doctor of the place and the nurse to continue managing the patient and not losing the relationship. I'm been clear?
Mm. Yeah,
Not
we
so, oh, go to the psychologist. No, it's here the psychologist. So let's talk about this case. Let's work together with this. And then when it's over, then the psychologist go to there. But it empowers the doctor, the team, the nurses, and everything else. Do you have
yeah.
something similar there, or it's not?
Well, we sort of we do. I think we're kind of we Queensland very strongly used that outreach model, the individual practitioners going here, there, everywhere, drive in, drive out, fly in, fly out. We definitely still use that model. Um, and we quite strongly used that model through the 2000s, I guess, late 90s and 2000s. That was pretty much the predominant model for providing allied health services and multidisciplinary care, including medical specialists as well. So the allied health would often travel on the same plane, or the same, would travel at the same time as the specialist. The dietitian would travel with the endocrinologist, who is seeing someone, who's seeing all the population of a remote center that have diabetes, for example. So we've used that model quite a bit, and continue to do so. I think what we've seen in especially the last 5 years or so, is a replacement of some of that travel, or in some cases all of the travel, with telehealth. So mental health, your example of psychology and mental health, we have services that deliver psychology intervention primarily via telehealth. Sometimes not completely, because sometimes it kind of depends on the complexity of the clinical area. But for example, we have a psychologist who works for a hepatitis B service as part of the multidisciplinary team. She covers a very large area, and the patients come in for their initial review with her. That takes a couple of hours. There's lots of testing. It's quite intensive. It's difficult to do that on telehealth, but most of the follow-up is via telehealth. So that would save her traveling out, or it may save the patient maybe 3 or 4 hours drive each way to come and see her, depending upon, sort of how the model works. So I think we certainly still have a lot of outreach, and where possible, I think teams try to travel together, or at least at a time which makes sense clinically. The dietitian travels with the endocrinologist, or travels after the endocrinologist, to pick up the dietetics referrals or changes in intervention that may be related to medical changes in the medical management of someone with diabetes, for example. But like I said, increasingly, I think that at least some of that outreach is being taken over by telehealth.
It's interesting because the last rural cafe that we had was about telehealth,
Yeah.
and yeah, it's so important for rural. It's a central topic because you need to communicate with the others,
Mm,
and this is crucial when you are in an isolated place or a remote area, and that's why one of the the reasons that telehealth is so important, and it's good um, for us to have, because I don't know if you have heard about it, but here in Brazil we have the very strong telehealth system. Like 3 years ago, for example, it started. But now, last year, they just cut it off
mm,
from, it was a national telehealth system. But now, thanks God, they came it again, and now they are, because they had cut it off about because the financial, but now they are just getting started again. So I'm very happy
mm,
about this, but it was a very good um, system.
mm,
You just called, and then the person in the phone would guide you through the diagnosis, through the the things that you have doubts.
mm.
It was
Yeah,
really nice.
I absolutely agree. We've seen it. It's been an absolute game changer for us. Like it has changed the way, it's changed the service model in rural and remote areas for us. We now have, so as an example, we have allied health assistants that are support workers that are trained, sort of workplace trained. So not professional level. They receive delegated tasks from allied health professionals. uh, 5 years ago, I could count on one hand the number of those that were in a rural or remote area, just because you need the allied health professional to be there to supervise them. But now with telehealth, we can do remote supervision, and we've seen a massive increase in the number of allied health professionals in very small, who are located in very small locations, towns of a few hundred people, and they provide the continuity of care. So they're the face of the allied health service and delivering care sort of 5 days a week, and then the allied health professionals, they come in via telehealth or by outreach to progress intervention plans or to do further assessment. So for us, without telehealth, that big change in terms of patient access to allied health services through an allied health assistant model would not have been feasible. So that's been a massive change for us. And then sort of at the other end of things, I guess we've got allied health professionals in rural areas that have been not able, and their patients who have been not able to access specialist services, who are now accessing specialist services in real time via telehealth. So an example is a model which is in development at the moment with physiotherapists in a remote area. The physiotherapists manage a lot of the chronic and persistent pain caseload, uh, and have done so in isolation or needing the patient to fly a long way, a few hours on a plane to get to a pain specialist or a rheumatologist or a medical specialist in the capital city. Now with telehealth, they're looking at an integrated model with the physiotherapist being the clinician on the ground, doing the assessment of the patient, and with the specialist, the not endocrinologist, the pain specialist or a rheumatologist at the other end, who will be observing the assessment, and then with collaborative decision making with the physiotherapist, the patient, and the specialist around what the appropriate intervention or the management strategy might be. So I agree with you. I think telehealth is the foundation for a lot of the rural and remote service models that we have now and will be developing sort of into the future.
So, Ilsa, we have a comment here from the Twitter. I asked, hey, what do you think about nurse and allied health in the rural scenario on Twitter of rural seeds? And then Matt Maisel replied and said, I would be lost without them. Yes, we all would be lost without nurse and allied health.
Yeah,
Good point.
I think that's a good point. And it is the team, because it's a small team, like there's often only one or two of whatever, there's a couple of doctors, there's 4 or 5 nurses, there's one physio, one OT, one speech pathologist, one psychologist. In rural tends to get quite cohesive multidisciplinary teams, possibly more so than urban areas, just because there's only a small group of people to draw on.
Yes, sure. Um, if you have any question, you that are watching us, or if you have any comment here, you can comment on our Facebook page, and you can comment also on Twitter with the hashtag Rural Cafe, or you can comment on YouTube here on the commentaries. Okay. So, Ilsa, do you have any question about how something works here in Brazil?
I think, look, I would just be interested as to whether, if if there is is similar work around a rural generalist pathway or rural generalist training or training positions, anything along those lines. Where in Queensland, well, within Australia actually, so Queensland and other states, Tasmania in the far south and New South Wales, all have rural generalist training positions. 5 states have rural generalist training positions. So, but we're very much in a startup phase. Some states only have a couple of them. We have about 30 or so. But we're interested in whether other jurisdictions like Brazil, other countries like Brazil, have something similar, because we're in a development phase. So we're interested in ideas from other areas.
Well, as a student, I know that, for example, in college, we don't have, um, actually, we don't have nothing about rural medicine. For example, people here think, oh, when you say, have you have you thought about how Brazil is a big country and how there are many areas with lots of people without doctor or without a health team in these places? People used to think, oh, I, for example, my friends in college, oh, I have never thought about this. And even some people that works in rural areas, like my teacher once, he said, oh, I worked for 10 years in a rural area, but I didn't know that it was actually a rural area. Like he haven't it was not clear for him that this place, that place was a different place from a urban center. So people here, actually, we don't have this uh, rural medicine so clear as you have in Australia. Even in the dimensions of our country, the medicine is very concentrated on urban centers, very concentrated, just as the schools medicine. But now they are doing some efforts to bring schools of medicine to the interior of the country, to the places not in urban centers. For example, my university here, it is not in the urban center. It is more on the rural. It's not rural. It is a city, but it is not the urban thing that the capital. It's not on the capital. But here we don't have uh, training on rural practice in college, and unfortunately, we don't have on our residency program. There isn't such a thing like rural family medicine on in the residency of family health. So uh, it's good to know that there is a group here in Brazil that they are part of the Brazilian Society of Family Medicine. That this group is trying to uh, do like on R3. I don't know how to say. It's just after 2 years of residency, you will have another year and then focused on rural health, rural medicine. But there isn't such a thing here in Brazil. If you want to do something in rural, if you want to be a rural doctor, you have to search for your own. You have to do, you just have to do um, intermedicine if you want. But even if you do family medicine residency, they will not teach you how are the specificities of rural because it is in the urban. But they are trying, and there are some uh, how can I say, there are also some students that want to do these internships on rural areas, and they are organizing it to make the student live that situation and like that situation, the situation of being a rural practice. But we don't have any formal program about this. Uh, it's a very good question for us to think about because just as half of the world is in a rural population, here in Brazil also, because we have um, some places with no doctors at all and no health units, and we have this necessity, but we don't have.
It's interesting. It's very interesting. I mean, I guess the Australia was, well, I would not claim to be an expert in medicine, the medical profession, but certainly just looking at it, we've looked at what medicine has done with their rural generalist pathway, and to some degree have replicated that within the allied health one. And I guess that would be my understanding is I think there was a time where medicine within Australia was the same. It didn't have a specific rural college. That's been around for about 15, 20 years, I think. Um, I think there probably was a time where there wasn't really a discipline of rural medicine, and indeed the a time when all of the medical rural general, all of the medical training, not rural generalists, all of the medical training was done within capital cities. The universities were solely in capital cities, and I think there was probably relatively limited training that was undertaken at undergraduate level, and then on specialisation pathways, internships, residencies in rural areas. They were very concentrated in large, big hospitals, basically. I don't know. I guess my reflection would be, or my experience from an allied health perspective is, I guess, just to relate to you exactly what our medical colleagues like Bruce Chater said to us maybe 5 years ago when we were starting our rural generalist pathway, that it really probably took about 10 to 15 years for medicine to get theirs. So we're 5 years in. So I don't know whether that's a good thing or a bad thing. I'll be in work for a while, I guess. But it seems to be, it just seems to be something that takes half a generation or more to progress, to build that understanding, or even the definition, which is what we've had to do within allied health, to define the competency standard, the competency framework, the education framework for what rural generalist practice is, because that didn't exist before like 6 days ago. We've just published the competency framework. So that building of both interest and also formalizing the definition. What is part of the scope? What are the key elements of a professional scope within rural? I think it does take a while. It takes a long time, is my experience, which you can probably tell from my wrinkles and tired eyes.
Well, but you are our inspiration, you know.
Perhaps so, but
Someone has to start. Someone has
yeah,
to start.
and that would be my tip. Like I think your focus, that focus on rural practice, that recognizing that this is a distinct area of practice with a distinct skill set that needs to be developed, I think, and then having champions like yourself, like your colleagues within Brazil that can progress that, or other countries that are looking at going down this path. That, I think, is the key. You just need don't need a superstructure, and you don't need a lot of money. That was our learning, because we have no money, or we have very little money. We're not medicine, so allied health don't get a lot of money, and we don't have a lot of resources. But if you have commitment from key people involved, then it is something that you can progress. Maybe not quickly, but it is something that you can continue to progress. So I think I'd probably pass on to you the advice that our medical colleagues gave to us 5, 6, 7 years ago, which is it does take a while. You need to have a longer term plan with lots of little milestones along the way. Publication of competency framework, the first rural generalist training position to be celebrated, but it absolutely is. I mean, you can see from other countries like Australia, where the development of a College of Rural and Remote Medicine, for example, has very much supported even the broader public understanding, but the professional understanding of rural generalist skills and what a rural generalist scope is. So it is a bit of a process, but I would encourage you to stick at it. You're much younger than me, so you'll get there way before. You'll have so much more of your life to get there compared to me.
Oh, but I hope that there's a generation of youth students getting more interested in rural here in Brazil, and also in the world, because I went to the conference in India, and there are so many young people there doing, yes, we have to go to the rural places, we have to care about their health. They are a population with minor access, because so I got really surprised and motivated to do this also. And when I hear you saying and other people saying the importance and the lack of people going there here, especially, I get more motivated to.
Absolutely. Look, I think we've always the published and stated goal of our work around rural generalism is to improve the health outcomes for rural and remote communities, rural and remote populations. And I think this is the hook of rural generalism, irrespective of your profession, medicine, nursing, physio, pharmacist, podiatrist, whatever you are, is that it's an easy one to argue. Like, it's not rural generalist training structures, rural generalist service delivery structures are easy ones to argue because they improve access for populations that have little or no access now. And what it means is that although we can't, although there will always be challenges in delivering health services to geographically dispersed populations, the limited access now means that any changes we make are substantial ones. We're not tinkering around the edges, we're making substantial changes, even within our own sort of scope of capacity to make those impacts. So I think it's a good one to, it's a good area. The rural generalist area is a good one. It's a good one for people to progress. I think although it takes a long time, negotiation with whatever medical colleges, professional associations, governments, reallocation of resources, these are all hard and long-term things. The underpinning component, improving access and health outcomes, is sustaining, I think, for people who are involved in the work.
Yes, I agree. I agree, Ilsa. So, I guess we are coming to an end. I'm just checking if we have any more comments here. Let me see. Just the comic sentence of Matt Maisel on Twitter. Let me check if we have any more comments. It was really good to know more. It was such a pleasure to meet you, Ilsa. And I really hope that you can come to the next discussions. Mayara is the main leader of this project, which I found so important, so beautiful. And actually, she's on the road now. She's on the road, so she couldn't come today. But it was really nice to talk about this topic. And if you want, you can check out the last Raw Cafe about telehealth.
I think I will. It's something we have a great interest in. Well, thank you very much. I've been very interested in what's happening in Brazil. And
Yes.
look, we are Queensland and Australia generally. We have a national allied health rural generalist pathway sort of steering group as such. And we're really interested if there's anybody online who has an interest in the work that we're doing or would be able to contribute some information about what they're doing. We're really keen to learn from what other countries are doing to try and address allied health workforce distribution in particular and service models in rural areas. So we have a lot of information on the Queensland Health website. If you search Allied Health Rural Generalist and Queensland, it will come up, including our contact details. So if anybody has any info, we're really interested.
So,
today.
Okay, so in Queensland website, we can find all this information too. Yes?
Yep, absolutely. The competency framework, education framework, we publish evaluation reports, we publish everything, basically. Just search Allied Health Rural Generalist Pathway and Queensland, and it will come up.
Nice, really nice. Oh, I'm really excited to know more about, and I'm going to search more in the Queensland website, and then we can talk more by email or if you
Absolutely.
want.
Yes, absolutely.
Okay. Okay, Ilse. So, people, we are coming to an end. our next rural cafe will be very special. It will be about leadership. So get ready, and everybody's invited to come and have a cup of coffee with us and talk about leadership on rural. The importance of this topic when you are talking with students, with doctors, with nurses, with uh, all kinds of professionals that works in rural. Okay, so it was nice to meet you, and we are
You,
coming to.
thank you. See ya. Bye bye.